Hello everyone, my name is Steve Hauser. I'm here today with Doctors Eric Peterson and Frank Sellke, who are chairs of our Committee on Scientific Sessions Programming. They've put together a wonderful meeting that's coming to an end, but it's been a great meeting, and we're here to talk a little bit about some of the highlights of the clinical trials that were released this year at Sessions. So, great job, congratulations. The meeting was just awesome, and I heard so many good things about the science that was presented here, so congratulations. I know how much hard work you two and your committee did on the meeting this year. So tell us a little bit about the highlights of the clinical trials, and I look forward to learning about them.
All right, well, thank you, Steve. The first clinical trial presented at the meeting was the Euclid Trial. It was a large study comparing patients with peripheral arterial disease, whether they got ticagrelor or clopidogrel, looking for cardiovascular outcomes or adverse cardiovascular outcomes. To a lot of people's surprise, there was absolutely no difference in those patients that got ticagrelor versus those that got clopidogrel. There was the same number of adverse events, so the trial was negative, but it was very highly regarded as a very well conducted trial.
A similar trial that had a negative result, which is actually could be considered a positive, would be the Precision study. This is one that looked at whether there was safety in celecoxib, a COX-2 inhibitor, and to see if those agents would be safe when used long term. Now, the results of the trial overall showed no increased risk among any of the drugs used as the nonsteroidal agents. There was a lot of controversy over that trial, though, with regards to whether or not the right population was enrolled. It was somewhat more modest risk than expected. Whether the right dose was tested, and in fact it was a low but on-label dose as opposed to higher levels used in routine clinical practice. And then some questions about dropout and crossover. Lots of that happened over the course of a 10-year study. All in all, reassuring, but still questions will remain.
Well, one of my favorite trials, since I'm a cardiothoracic surgeon, was the ART trial, the arterial revascularization trial. Now, everyone thought this trial would be positive. It compared a large number of patients, over 3,000 patients, randomized to receive 2 internal mammary artery bypass grafts versus a single internal mammary artery bypass grafts. The traditional wisdom is that the more arterial grafts that are performed, the better the operation, the better protection someone has from cardiovascular events and recurrent angina. Surprisingly, there was absolutely no difference in the condition of these patients at 5 years. There was no reduction or difference in death, myocardial infarction, stroke, recurrent angina, need for repeat revascularization, or quality of life. This was very surprising, and the feelings by the presenters there is that at 10 years there will probably be a difference, but certainly at 5 years there was no difference between these groups. What was different, the sternal wound infection and complication rate was considerably higher in those patients that received 2 internal mammary arteries. So that should also give us some caution on how to perform bypass surgery.
As a cardiologist, I'm going to try to prevent them from coming and visiting you. So for my idea, it was actually the prevention studies that were most meaningful. There was a series of these at the meetings, looking at the PCSK9 inhibitors, as well as ApoA1 Milano, a very interesting agent, as well as some of the other novel agents used to lower lipids. All of them showed success in lowering lipids, but there was variable results, some of them positive, some of them negative, with regards to their ability to actually shrink atheroma. None of these trials, unfortunately, yet are powered to look at outcomes, but many of those are in the pipeline to come.
Another interventional trial was the FUTURE trial. It compared patients that underwent a fractional flow reserve assessment of coronary lesions versus the traditional angiographic assessment. Now again, the traditional feeling is that patients that undergo fractional flow reserve analysis of the lesions have a more precise handling of the vessels and the lesions. You can prevent doing interventions on certain patients, and certain patients can get a PCI when they need it. Again, surprisingly, those patients that underwent fractional flow reserve assessment actually had a higher mortality. It was a relatively large trial, but the trial was stopped prematurely because of these increased incidence of adverse events. So again, this has to make us rethink how we're going to assess patients with coronary lesions destined for either PCI or coronary surgery.
One final one, which was meaningful for me from a prevention angle again, was HOPE-3. This study looked at the question of whether or not blood pressure lowering, as well as lowering of lipids, would change cognitive outcomes. Now we know from a series of large studies that in fact controlling blood pressure and controlling lipids is good from a cardiovascular standpoint, preventing subsequent events. This study tried to see, could we improve cognitive outcomes? Over the course of 3 or so years, in fact, we were not able to show a difference in cognitive outcomes, but there was no harm associated with statins, another concern that had been raised. But I think what's really needed, and most of the commentators discussed this, was longer-term studies, ones that begin earlier on in the disease course and will continue over perhaps a decade or more to be able to see these differences.
The final interventional trial was the Gary trial. It came out of the German aortic valve registry. And what they did was examine retrospectively the outcomes of patients that underwent surgical aortic valve replacement for severe aortic stenosis versus those underwent a transcatheter approach or TAVR approach. Now there's the recently published Partners 2 trial that demonstrate a small but statistically significant advantage of TAVR in the intermediate risk patients. These are patients that have about a 5% risk of mortality. In that study, TAVR clearly showed a benefit. Now this trial, while it was a retrospective analysis, really didn't show that. The surgical patients actually did better. However, the patients that receiving the transcatheter aortic valve replacement or the TAVR were much sicker. And they tried to do propensity matching, but I don't think if the groups are that different, you can get a good assessment of the relative outcomes. So while the surgical patients did better, I'm not sure this study clearly demonstrates that TAVR is inferior to surgery in these cases. However, what is important, there's certain evidence right now shows that these valves, the ones that are placed percutaneously, only last 8 to 10 years on average, whereas the surgically placed bioprosthetic valves last 15 years or more. So in intermediate risk or low risk patients, my feeling is that we should still probably do a surgical aortic valve replacement. But again, this is a very rapidly changing field. And there are trials undergoing right now, both in Europe and the United States, looking at not only the intermediate risk patients, but the low risk patients. So hopefully in a couple of years, we'll have the answer to this. But again, the field is being transformed all the time, and it's very rapidly changing. So I think in the future we'll know the answer, but at this point we don't.
Finally, Steve, it would be remiss not to note all the phenomenal basic science work that was done here. We had over 5,000 presentations, many of them outstanding ones in the fields of basic science, a whole day devoted for stem cells, a whole day devoted towards precision medicine and the launch of it, and obviously your presidential address was amazing.
Thank you so much, and again, thanks for all you did to make this a really great meeting. And we'll see each other again in Anaheim in 2017.
Can't wait. Thanks again.